Okay, welcome everyone. Thanks to everyone who's joined. Today we have Dr. Dena Schulman-Green to discuss her pilot project and tips for conducting qualitative interviews in the palliative setting. Just a couple of housekeeping items. All attendees are muted and video cannot be turned on. We also ask that you please use the Q&A feature to type in your questions, which is a button at the bottom of your screen. And if you have any questions that come up that are more technical, like if you're having trouble hearing, we ask that you please use the chat feature to contact me and I'll do my best to help. Please share your questions and comments at any time and we'll answer those in the last 20 minutes of today's webinar. Also on our panel today, we have Dr. Catherine Pollack, the co-chair of the PCRC and representing the executive committee. So I think we can get started and I'll ask Dr. Pollack to please formally introduce our speakers.
Happy to do so, Naomi. Thanks so much. It's my pleasure to present and introduce Dena Schulman-Green. She's an associate professor at New York University, Rory Myers College of Nursing. Her research focuses on the timely integration of palliative care into patient and family management of serious chronic illness. Her education spans counseling psychology, gerontology, and palliative care, and her training in this area has led her to appreciate the specialized approaches that are needed when conducting research with these vulnerable populations. She routinely incorporates counseling techniques into her research with patients and family caregivers, many of which she will share with us today. She consults on qualitative and mixed method studies nationally, and her work has been funded by the National Institutes of Health, the American Cancer Society, the NPCRC, and Gentech, among others. She was a recipient of the 2017 PCRC Pilot Award. She also heads our membership committee, so we're really grateful for her service in that. And her presentation is going to talk about some of the pilot work that she's done. And so with that, I will turn it over to Dena, and thank you so much for presenting today.
Thank you, Catherine. I really appreciate the invitation to be here. I'm very excited to speak with everyone today. And I also want to thank the PCRC for the pilot funding. Our project is now complete. The publication just came out, and the funding really has helped us to advance self and family management science, and also has helped me to make the case for an R01 proposal on increasing healthcare literacy in palliative care among diverse patient and family caregiver dyads. So I'm very grateful for that. I want to start today's presentation by telling you a bit about the pilot project, which was a metasynthesis of what family caregivers do to support patient self-management of serious illness. So these were all qualitative studies. Most of them were interviews to learn about family caregivers' experiences caring for patients with serious illness. But I want to spend most of the time today talking about how we do qualitative interviews in the palliative setting the way that these study authors did. So just to orient you to what the project was and the contributions that I hope that we've made, I want to show you the self and family management framework. So you'll see that on one side we have risk and protective factors, and on the other side we have outcomes. And linking those, we have self and family management behaviors. But you'll see that there's sort of like a black box in the middle here. So we see that there's co-management of serious or chronic illness between patients and family caregivers, but it's not really specified exactly what those behaviors are and what might influence those behaviors. And so in our previous work, we did two metasyntheses of what patients do to manage serious or chronic illness and what kinds of things may help or hinder them in doing that. And the PCRC pilot project allowed us to do the same for family caregivers, but we did those within the same metasynthesis. So I want to just share that these are the slides that I presented in the Data Blitz presentation that I did in the in-person PCRC investigator meeting a couple of years back. So for those of you who are thinking of doing those kinds of presentations, this might be an example for you of what those slides might look like. So I do want to acknowledge my team members who were amazing: Nick Dion Odom, Shalee Feder, Janine Batten, Victoria Jane Unlong, Yolanda Harris, Abby Wilpers, Tiffany Wong, and Robin Whittemore. So I already explained what the purpose of the study was, and I mentioned that we did a metasynthesis. And in the study, we looked for titles or abstracts in databases that included self-management or self-care in the title or abstract. And these were primary reports from family caregivers of caring for adult patients with advanced life-threatening illness. And we extracted and coded those practices and facilitators and barriers that were identified in the articles and collapsed similar codes into categories. And of course, used the usual PRISMA and CASP guidelines for metasynthesis work. And from about 1,300 articles, our sample ended up being 30 articles that were published about across 2 decades between 2000 and 2017. And they represented 935 family caregivers with a pretty wide age range between 18 and 89 from 8 different countries. And the main disease groups that we found were cancer and heart disease. And we also had some caregivers who were helping patients with progressive neurological disease, diabetes, COPD, and then a pretty sizable number, about 40%, of other diseases. And so, in terms of our findings, they fell really into 3 buckets of what kinds of practices family caregivers were engaging in. So, the first bucket was focusing on the patient's illness needs. Then we had activating resources to support oneself as the family caregiver, and then living with someone with a serious chronic illness. So, in the first bucket, these were about the tasks and skills that enabled the caregivers to learn about the patient's illness and what they needed to support them in that illness. So, an example would be learning about exactly what that disease was and what went into the management of it. For example, medication management for a serious condition. Another was providing emotional support to the patient if they had just been diagnosed, how they were feeling about the diagnosis. So there were many tasks and skills in those in this bucket, but these are just 2 examples of that. In the activating resources category, these were the things that really enabled the family caregiver to sustain and optimize their role. So these were things like psychosocial resources like respite care to enable them to take a break, or spiritual resources that would sustain them, like praying. Living with a serious chronic illness was really about caregiver self care. So, what they needed to do to care for themselves physically and emotionally in terms of adjustment to enable them to sustain this role. We identified a very wide range of emotions among caregivers. Most of them, I will say, were negative, things like being overwhelmed or feeling anxious, but we did find a range of positive emotions as well, things like gratitude or meaning making or loving the care recipient even more. But other pieces of this self care were learning to adjust to this new role. For people who get thrown into the caregiver role, it can be a really new and overwhelming feeling, accepting the situation when life has changed and is not going back to the way it was before, and then developing the confidence to serve in this caregiver role by feeling like you have the self-esteem and the toolkit to be able to serve in this role was something that people needed to learn over time. In terms of the factors that influenced family caregiver practices, we found 5 different categories. So, one was personal characteristics, and within that was their knowledge of treatment options. And this included their understanding of palliative care. And it also had to do with how willing and able the patient was to engage in self management. So, some patients wanted to engage, but either didn't have the skill set, or they just didn't have the physical stamina to be able to engage, or they didn't have the emotional readiness to engage. So, as you can imagine, the less empowered or engaged the patient was, the more this would put on the shoulders of the caregiver. In terms of health status, the health status of both the patient and the family caregiver came into play as an influencing factor, where, of course, as I said, if the patient was more debilitated or was having a harder time coping, that would make things more difficult. But also, if the caregiver had their own issues to deal with, if they were feeling overwhelmed, if they had their own physical limitations, that certainly affected their ability to support patient self-management as well. Resources like socioeconomic status, access to things, assistive devices, was another influencing factor, as you might imagine. Environmental characteristics, for example, the quality of family relationships. What was the patient and family caregiver relationship like prior to diagnosis? What kinds of dynamics were being brought into play or were exacerbated after the diagnosis of the illness, or an uptick in the illness that required a family caregiver to step in? And then things outside of the family, like public awareness of the health condition. What kind of information was out there to help family caregivers navigate a particular health condition? Is there stigma around the health condition? And then also, what kinds of resources would be available in the community to support family caregivers as they supported patients? And the last category was the healthcare system. As you would imagine, issues like access to care, if healthcare providers were coordinating among each other, if there was consistency of healthcare providers. If you've ever been a family caregiver yourself, you know that this is a really potentially maddening area when you're trying to be the ringleader among many different providers who are not speaking to each other and sort of all on their own island, and it becomes very disorganized. And then, of course, the quality of communication with healthcare providers with, is the family caregiver being heard? Are they being respected as an agent of the patient? So one thing I will say, in identifying all of these practices and influencing factors, we didn't saturate in all of these categories. We had 30 studies. It's really not a lot. It really points to the need for more work in this area, and that we also need to look at the quantitative literature to be able to flesh out what we know are probably a much wider range of influencing factors that affect family caregivers. But one thing that's pretty clear is that the family caregiver role is very complex. There are a lot of tasks and skills that go into this role. And I mentioned that there was a huge range of emotions that family caregivers identified. And so, given this emotional toll, it's really important for clinicians to bring the family caregivers out of the corner and to assess what their needs are for support and what is the impact of caregiving on their quality of life. Because obviously, if they're highly distressed or if their informational needs aren't met, they're not going to be able to sustain the role. So, that's pretty important, and also indicates the need for interventions to support family caregivers. It always bothers me when family caregivers sort of just expected to figure things out on their own. And again, they may have their own health issues, and it can be very distressing, and we absolutely must provide support to them. So things like case management, holistic management by healthcare providers, meaning taking care of the patient and the family caregiver together, and in all of the ways that we would expect that we do in palliative care all the time, of physical and emotional and social and spiritual and all of these pieces. And then for there also to be government support of caregivers, either by paying family caregivers or allowing flexible times and jobs, can also help support caregivers as they support patients. So, our next steps are to revise the self and family management framework again to include these family caregiver processes and factors, which incidentally very much mirrored the practices and facilitators and barriers that we identified among patients. So, that's going to facilitate, I think, our redesign of the framework. And then, of course, we want to continue to use the framework to support studies of patient and family caregiver co management of serious chronic illness. So I want to transition now over to talking about how we do interviews in the palliative setting. So if you think about like all of these 30 studies, how did the investigators get this kind of data and talking about emotions and talking about what is this like for you to people who are, potentially and probably distressed in a really difficult situation and feeling just sort of maybe sorry for themselves and feeling bad for the patient and saying, why me? And all of these kinds of concerns that family caregivers have. How do you talk to someone about what that experience is like? Because there really is sort of this double whammy that you're talking to people who are potentially highly distressed about a pretty emotional or sensitive topic. So we have to use these tailored techniques to get the data we need and to support these vulnerable participants at the same time. So just because I'm sure that there is a range of experience in qualitative interviewing on the call, I want to just step back and talk a little bit about qualitative interviewing in general. So these are, of course, versus quantitative interviewing, which is basically surveys. And we do qualitative interviewing to understand what people know or do or feel about different social phenomenon. And we can use interviews to explore phenomena that we don't know that much about, or to explain phenomena that we do know something about, but we want to dig deeper into some aspect of it. And of course, interviews can be either individual or group, where group interviews are focus groups. So I know many of the people on this call are clinicians, and I want to talk a bit about the difference between clinical and research interviews. Because in both, as you know, it's important that we build rapport, that we ask questions, that we listen very carefully, and we use similar techniques. So we reflect back how we think the patient, for example, is feeling. We interpret what they say so that they can see that we've understood what they've said. We summarize so that we can move things along and hopefully come to some sort of a decision or moving ahead with getting data. But the main difference is that clinical interviews have therapeutic intent, that in the end, we are going to make recommendations or give some sort of advice, and our goal is to make the patient feel better. But in research interviews, we do not do this. There is no therapeutic intent. We certainly want the participant to have a good experience as part of the interview, but we don't provide advice in the end. And it's really important to make that very clear. And so for people who wear both clinician and researcher hats, it has to be really clear what hat you're wearing in the interview, both to you and to the person that you're interviewing. So I want to talk just for a second about different types of interviews. So we have structured interviews where the interviewer is sort of more in charge and most of the questions are yes, no, and you're sort of like a computer. You're asking the same questions in the same order every single time. An example of this would be like a symptom checklist. And then in the opposite extreme, we have unstructured interviews where the participant's the one who's completely in charge. And we as the interviewer basically give them a topic and say, have at it, and they'll go where they're going to go in terms of the content with few, if any, probes from us. And that's mainly in sort of like a case study kind of interview. We don't use unstructured interviews super often. So really the most common type of interview is the semi-structured interview. And you'll see this referred to sometimes as an in-depth interview or a depth interview, where the interviewer and the participant are partners in the interview. And so we have our set questions, but we can do them and ask them in different orders. We ask probes, and we have a lot of flexibility in doing that. I like to think of doing interviews as getting into a fishbowl with the participant. Why? Because it's sort of like a world within a world. And our job as the interviewer is to set that world up in a way that we're going to get the data that we need and that the participant is going to feel comfortable, and that you as the interviewer are also going to feel comfortable with how the interview goes. And so we're going to talk about different techniques for how you're going to set up that fishbowl for success. I've divided up the tips into kind of different phases of the interview process. And the first one is enrollment and consenting, because the truth is that most people are going to decide if they're going to participate in your study the first time that they see you. And so they need to see that you're someone who is friendly, who is respectful, who explains things, clearly to them, because they ultimately, if they're going to give their time, they want to know that they're going to have a good experience, that they're going to feel safe, that they're going to feel trust. So what are some ways that we can make this happen? Well, one thing it's great is to have someone, and if you're doing enrollment in an institutional setting, it's great to have a staff member who your potential participants know, introduce the study to them, and to other staff members, because all of those people are going to help with enrollment into your study. And so if that one staff member, that friendly face, is someone who you know, who you explain things to, that maybe you can get into a staff meeting, bring food, it always helps, and say what you're doing and show them how you're going to be taking care of these people that they take care of, they're much more likely to feel safe in referring their patients to your study. This is also particularly important with family caregivers. So family caregivers may be the focus of your study, but if you're recruiting in an institutional setting, often the family caregiver is going to be there, and they're obviously going to be protective of the patient. And so if the staff member who the family caregiver knows says, "Don't worry, this is a good study, we know about it, we're good with it, we think you might be interested in it," it goes a long way towards the family caregiver feeling comfortable, or the patient feeling comfortable to participate. We often think about informed consent as just housekeeping, but the truth is that the patient's participation in the study, in a way, or the potential participation, begins when you get informed consent. So even though they're not technically in the study yet, your relationship with them has already begun. So it's really important to take time with obtaining that consent. It's really an opportunity for rapport building, so that if you're explaining things really clearly and you go up to them, you say, introduce yourself and hi, and you have a smile on your face, and again, you're clear and you're respectful, that will set the tone for the later parts of your interaction, assuming they agree to participate. The other piece is that the consent process can be very overwhelming for people. It looks like a contract. We make them sign it. Sometimes there's this, technical language in there, as much as we try to simplify it. And it can be very overwhelming for people. So it's important to take the time to make sure that they really understand it. But for those of you who have enrolled participants face to face, you know that most people don't actually review the consent form. They should. But most people will rely on your verbal description of the study to decide if they want to participate. And so it's important then that you cover exactly what needs to be covered. And again, this is all part of the rapport building process. So do use informed consent as a piece of that. Obviously, it's very important to make sure that they understand the purpose of this study. There are a few reasons for this. We know from the literature that even people who are, distressed or feeling ill or in these difficult situations, do perceive a high value in helping others through their participation in research. So when we explain, here's what the study's purpose is, and here's how you can help us, they're oftentimes on board, even if they're not feeling great, or even if it's something hard for them to talk about. They feel something altruistic, and so it's important to emphasize that piece to them. The other thing is that it's important that they understand what you're going to be asking them, because we don't want them to be surprised later, especially if it's a difficult topic. We don't want them to be surprised later that there was some sort of a bait and switch. So you need to be very clear about, here are the kinds of questions we're going to be talking about. And it's important to do this because we're always excited when someone says yes to participate in the study. But if they say yes and they really didn't understand, and now we start to ask questions, they may not want to answer those questions, and then you're not going to get the data that you need. So it's really important that they understand what the nature of their involvement is. Another thing that's really important, particularly with debilitated patients, is that you have to have the flexibility to conduct an interview, maybe not when it was planned. Sometimes you have an appointment and everything is settled, and then the person doesn't feel well. If you're interviewing, for example, in the hospital, you might get interrupted. Someone comes in to take vitals, there are visitors, whatever it is, and you have to either stop the interview or reschedule the interview. I used to walk around in the hospital with kind of a briefcase with everything I needed in it. So you have your consent forms, your recorder, your interview questions, everything is ready, because sometimes I would go into one patient's room and there was a visitor there, but there was someone else who was on my potential list a few rooms down. And so I could go in there and see if I could interview that person in the meantime. So you just have to be really flexible to what might happen when you're working with people, again, who could possibly be debilitated or have interruptions for whatever reason. So there's this interesting time in between consent, but before you've started the interview. And it's a really excellent opportunity for continued rapport building. So this might happen like if you're walking with the interviewee, if you've met them, for example, at the door of the building and you're walking to the room where you're conducting the interview, or they've been brought to the room where you are and now they're getting settled with taking their coat off. And so you can sort of engage in some small talk and get a sense of who they are and how ready they are for the interview. And it's really important to get a sense of them. And the reason is because if you put yourself into their shoes, we are asking them to talk to you, who presumably is a complete stranger, about these really emotional topics that they may not have really thought about before. That a lot of these times, this is the first opportunity someone's had to talk about something that's really important, like stigma, like dying, or whatever it is. And so we need to make sure that they feel safe and that they can trust you. Um, Talking about these topics can produce really strong feelings. They might not even be aware that they have these feelings until they start talking to you about it. And one of the possible things that can happen is that they over disclose because they haven't, again, had a chance to think about these things. And so that's a little bit of a tough thing to gauge, because you want to give people the chance to speak, but you don't want them to feel like they've revealed more than they wanted to during the interview. And so you really need to sort of get a sense and make sure that they're kind of on track, and just to be mindful through the whole time of the patient's well-being. When there's this safety and trust, you will get better data. There's no question about it, because they will go as far as they are comfortable going, and they may be willing to go a little further. But again, it's the trust is really important in making that happen. So, some easy ways to develop rapport is, so for example, if you're going to do an interview at hospice, you don't pretend like you're not at hospice. If you know that they just arrived there, you can imagine some of the things they might be feeling. And so you acknowledge that. I know you just arrived here a few days ago. How have you been adjusting to being here? That might not be part of your agenda, but it's kind of the elephant in the room and is a question that may need to be asked. Another thing is that clearly with debilitated participants, you need to be sensitive to what needs they may have. Sometimes when I was doing interviews in the hospital, they were thrilled to have someone come in the room because they couldn't get out of their bed and they were cold and they needed a blanket, and the blanket was on a chair that was too far from the bed. They couldn't get it themselves. So be alert to those kinds of things. Do they need something to drink? Do they need a tissue? Is there anything you can get for them so that they can be settled and prepared for the interview? Again, it can happen depending on the setting. If someone comes in the room, if the phone rings, again, if someone comes in to take vitals, I would always ask, should I step out of the room? Be respectful of their privacy. It's sort of a bummer when you get interrupted like that, but it's just sort of par for the course. The environment is really important as a rapport builder. I think people generally know this, but I think it's worth repeating that the environment needs to be quiet and private and comfortable and distraction free and convenient for them. And if it's a place that they know, so for example, if you have someone who's coming to you, if it's a place that they know already, like somewhere in the hospital, for example, that always makes it easier for people to come. And when you're working with vulnerable populations, again, people who aren't feeling well, you have to make it as easy as possible for them. The other piece to think about with the environment is the quality of the audio. So you have to scope out a place before you conduct your interviews there to make sure there's not an air conditioner buzzing in the background or ambulances going by, because patients who don't feel well may need to speak in a very low voice, or they may tire easily. And these kinds of things are going to affect the quality of your audio. So again, you want to set up the fishbowl for success, because if you can't hear your data, you can't use it. I want to bring to your attention an article that I came across by Dr. Fradkin, which was on the CAPC website, and I have the resource listed for you later, which was about setting up clinical encounters via Zoom. But a lot of the practices that he talked about are absolutely applicable to research interviews as well. So of course, he also talks about the environment, but the other pieces that he brought up are really important, especially now when a lot of interviews, if not all interviews, need to be taking place remotely. So some of the suggestions that he had were being mindful of what's in your frame to make sure that there's nothing unusual or something you wouldn't want people to see, use of warm lighting, having a stable device, both in terms of the internet connection and not using a device that's going to wobble everywhere, keeping the camera at eye level and matching the size of your face to their face. We know that a connection is made when you are interviewing someone, when they start to mirror your gestures. So, for example, putting your hand up to your face, you'll see sometimes they'll do the same thing, and you'll see that you're in sync when those kinds of things happen. And so, when we're in a remote setting, a way that you can facilitate that is to make sure that you're matching the size of your face to their face in the Zoom frame. And then also, it's a little bit weird. I think a lot of people are used to Zoom interviews now, but I think that acknowledging that it's a Zoom interview can be helpful, just to say, hey, this isn't the norm. It maybe isn't ideal, but this is the best we've got right now. So the goal that we want to get to in these interviews is the point where we can get to the most sensitive issues, which we usually put sort of in the middle of the interview guide. So again, you can have this rapport building and the participant can feel comfortable to get to that point with you. But before you get to that point, you kind of need to see, like, what kind of interview is this going to be? Because some of them are great and some people, they just don't end up sharing a lot. But you want to sort of gauge what this participant is going to be like. What's their story? What do they understand about their condition or whatever you're talking about them with? How comfortable are they discussing this? And you will get this from that pre-interview talk, and you'll get it from the early phases of the interview. You might be able to get some information from the staff member as long as all the HIPAA stuff is in place and you can actually speak with them. So that's pretty useful also, but using this pre-interview talk is a pretty effective way of getting this first sense. So interviews have a structure. There is a beginning, a middle, and an end, where again, this beginning is the rapport building and immersing into the topic and getting the juices flowing. The middle is getting to this main content where the most sensitive questions are placed. And then there's an end part where it's wrapping up and reflecting on the experience and making sure that this person is going to leave the room feeling, again, like they've contributed and they're feeling good. So it's really important. It's not just jump in and ask your questions. You have to follow this beginning, middle, and end piece. So let's talk about each of these pieces. So most people know about interviewing that you start with this broad open-ended question. A lot of times it's called the grand tour question. And it's just this broad question that, again, helps to get those juices flowing. Can you tell me what you understand about your illness? I mean, obviously, the grand tour question should have something to do with what your topic is, but it's, again, just to like let them settle in and for you to get a sense of how are they responding to this question? How detailed is their response? Are they emotional about it or not? What kinds of things do they keep touching upon? And then you can follow up according to what their response looks like. And we start with this non-threatening question, again, to build rapport with them. We have to get a sense of how willing they are. So they've consented, but sometimes people consent and then they don't really participate, which is a little baffling, but it does happen. And so we want to get a sense of how into this interview were they going to be and are they ready for it? I usually plan on a 45-minute or less interview, particularly if I see a person is pretty sick. It might be 30 minutes or even less than that. So you need to get a sense of what that timing is going to be. And I also like to let them know approximately what our time will look like together so that they're not going to be nervous if they're not feeling well, that I'm not going to keep them for an hour or hour and a half. And the other thing is to gauge how they're doing throughout the interview to make sure that they're not getting fatigued, or if you see they need to shift position or something. And you may need to take a break in the interview, and sometimes you need to schedule a follow-up sitting if they really can't tolerate being with you for the whole time. So those are just things to keep in mind. So with the middle of the interview, you really just sort of have to go with the flow. Sometimes you ask a question in a lot of different ways and they don't respond. And usually this indicates to me, sometimes it may be that you have to work on the wording of your question, but sometimes it says they're just not comfortable with the topic. And so you might need to just drop it, or you can possibly ask about it, but you'd have to see if you think that's appropriate or not. they may not tell you how comfortable they are or not they are. And so using those verbal and nonverbal cues is really important to get a sense of that. And at the end of the day, you just sort of have to be satisfied with the extent that they invite you into their world. They may be willing to go only so far, and that's it. And that has to be good. The other thing is you may see that their demeanor fluctuates. They may talk a lot and then sort of pull back a little bit. And it may be important to you to focus on the emotional content of what they're saying. It may be important to you to say, gee, you seem to, go back and forth in wanting to discuss this. It's always an issue that comes up in interviews of which way you want to go if someone says something, and are you going to go with the emotional content or are you going to go with the substantive content? And so that's a decision that you need to make, and you need to go in the way that is pertinent to what you're studying. So I always like to think about an interview again with starting with this safer ground and peeling back the layers till you get to those most sensitive questions. So I start with the safer questions. I plant the sensitive questions in the middle. I try to get a sense of what's happening. What do they think about each of these questions? What's the picture that's emerging? And through the probes and the questions that you ask, you eventually get to the point where it just feels ready to get to those hardest questions. But you just have to engage in that process. You can't go straight for the $1,000 question. There has to be this peeling back the layers process. And it may also be helpful to alternate between more and less sensitive questions so that they have a little bit of a break. If you can't just move slowly through the questions so that they're not overwhelmed, especially when you're asking the difficult questions. It's good to go through one topic at a time, not to talk about one thing and then talk about the next issue and then to go back to the first issue again. This really throws them off. And it's good to memorize the interview questions so that you can smoothly cover all the topics. And that generally happens after the first few interviews, that you just know what the questions are anyway. So you need to be prepared to follow them where they go, because we are very careful about thinking about what we want to talk about, but they may think of other directions or answer in questions that seem to take you off topic. So you need to think about where that might happen, and you may need to adjust your questions, but it's good to think about what are the unintended directions questions might take, and to think about what your reactions will be to them if participants do go in that direction. It's also good if you know you have a really difficult question to ask, like, what do you think dying is going to be like? You need to practice asking that so that you can ask those questions in a way that's not value laden or not overly emotional, and to think about what's the right wording for this question. So, when we get to the end of the interview, again, we've been talking about this sort of slow immersion in of all of this rapport building through consenting and where they are and getting a sense of who they are. The same thing is, again, to have the slow progression out. You can't just sort of ask again one of those really loaded questions and then be like, okay, thanks very much, appreciate your participation. They're just sort of left, feeling out of sorts. And so, taking the time to have this slow progression out is really important, and even letting them know. So I usually give people a heads up 5 or 10 minutes before our time is up to say, okay, so I have just a few more questions to ask you, or we're going to begin wrapping up now. And this is the time to help the participants to feel, again, like they haven't over disclosed, that they're safe, that they've been heard, that they don't, feel foolish in any way. One of the most common questions I get at the end of an interview is, did I do okay? Did I help you at all? People have a lot of anxiety about, were they a good participant? And so we need to make sure that they know, no matter what they told you, that it made a contribution, and that we appreciate their participation. So another way that we can help them to feel good about the experience is just to acknowledge what they've been through. Like, wow, it sounds like this has been a really difficult time for you, and I want to thank you for sharing your experience with me right now. The thank you goes a long way. I know it seems very simple, but it does go a long way. We also want to end in a way that allows the participant to reflect. And so, again, that's why we open with safe topics, we close with safe topics, and usually end with this broad question. So it's sort of like the analog to the grand tour question we start with, is that we end with this broad question always, is there anything else that you think is important for us to know as we are learning about whatever your topic is? So they may bring up things that you never thought about. This will really help you to revise your interview questions for the next interview. And it also gives them a chance, if there was something that they didn't fully get to talk about earlier in the interview, that they have an opportunity to get it off their chest and to feel like, okay, I said everything that I needed to say. It's also useful in your final questions, particularly for when you're first using an interview guide, to ask, what was this experience like for you? It helps you to, again, refine what your interview protocol is, but also for them to see, like, what was this experience like for me? And they can hopefully reassure themselves, like, this was hard, but I'm okay. And I feel like I, accomplished something, and I was a good partner in the fishbowl experience. And the most important thing is, we get to the end of the interview and we think everything's wrapping up. And most people turn off the recorder after that. Is there anything else you want us to know? And often they'll say, no, I think I've covered everything. And people turn off the recorder. Don't turn off the recorder. Very, very often, as soon as the participant feels like the formal part is over, like, you'll see them, you'll turn off your recorder and they're like, and they lean back in their chair and they're like, wow. And that's when they start to really tell you what their experience has been like. And I think it's just that, even though they usually forget that the recorder is there after the first few minutes, there's something about, like, feeling like they're done and now they're just chit-chatting with you, that they feel more comfortable in sharing, and in sharing the really important stuff. So don't turn off the recorder. They should know that, this is still part of the interview, but don't turn that recorder off really until you're actually done. So another piece that's very important is, again, what about you as the interviewer in conducting what can be very difficult interviews? So again, as I touched upon earlier, wear only one hat. This is not the time for you to share experiences. If you had a family member in hospice or something and you're talking with someone in hospice, this is not the time to share what that experience was like for your loved one or for you. It is not the time to educate or to do any kinds of counseling. Again, this is really hard when you're a clinician and you're just pulled, that your soul is saying, I want to help this person. I mean, it's very, very hard, but you must understand that this really blurs your role for your participants. They need to know that you were there just with your researcher hat on, so that they know that they shouldn't be asking you questions about a medication they should be taking. They should know that you're only there to listen to their experience about your topic. So that's something that it's good to even prep for if you feel like it's going to be difficult for you to do. And so you could speak with team members about that, or even write down, what do I think might come up for me in the course of interviews on this topic. So again, the same as in the clinical setting, these kinds of interviews can be really emotional taxing, and it's really important to engage in self-care. So gauging the depth of your involvement in an interview is important. If you're getting too sucked in, if you're getting emotional, those are things you need to go and talk with team members about. Maybe think about, are you the right person to be doing these interviews, or what you need to do to be able to engage in these interviews. The other thing is that it can be difficult. Some participants you just really click with, and it can be difficult to break the intimacy that develops because you're in the fishbowl together, right? And you've set up this fishbowl for good rapport, and it can be really easy to identify with the participant, or I should say even over-identify. So that's really tough. And so you really need to think about, how are you going to achieve this ideal practice of being present enough to understand the participant's world, but distant enough to be able to get through your interview questions and get the data that you need. So it's really something to think about and prepare for. Another piece of self-care is to be alert to your feelings and reactions about your topic. It can be easy to burn out. You might have an unanticipated reaction. You don't want that to happen in the middle of your interview. So again, processing with a team member is really important, to get things out on the table and to be able to dive back in. And another really easy technique is just to leave time in between interviews. I mean, I've done 3 interviews in a day. I will say it's really difficult for emotional reasons sometimes, but also to engage in active listening for that long can just be really difficult. So either if you have a few interviews in a day, I would leave time in between them, or even leave, a few days in between interviews if they're really difficult to do. So I want to leave you with a few resources that I mentioned. The Fratkin article is here. The article that came out of the PCRC pilot study is the second study here. And then many of these techniques that I've spoken about with you today are in this article, Tailoring Traditional Interview Techniques. So I hope that will be useful to you. I use these techniques all the time. I find them to help me. I think that they've been very helpful for study participants. And I just want to add, when people say, like, how do I know if it's a good interview? And I think there are 2 ways. So one is that you leave the interview and you're like, wow, like I already know the quotes that are the juicy quotes from this interview and just perfectly illustrate, something that I was interested in exploring. And that feels great. Sometimes you leave the interview and you're not sure how it went, but when you get to the transcript, you can see how great it was. And literally, when I say see, I do mean see, because you can tell a great interview from the transcript when you see a question from you and a long paragraph from your interviewee, and another little probe from you and a long paragraph from them. So listen, it could mean that they were just, you hope that they're not just talking and off topic, but you'll see that it means that they were engaged, that meant that they felt comfortable. And again, it's not you talking. The point is not your day, your topic, you need to know from them. So just that first look at the transcript is going to be a good indicator of how well it went. So I hope that these topics are useful for you, and I'm happy to take questions now.
Thank you so much, Dr. Schulman-Green. We have lots of great questions coming in through the Q&A feature. First, were there any differences in FC's need for support, confidence, ability to manage the emotional toll, etc., with the type of FC, such as a spouse, an adult child, or other?
Dena,
So,
can I
yeah,
also ask you to stop sharing so we can see each other? That was
yes,
fantastic
absolutely.
presentation. Thank you so much.
Okay. So the truth is that I don't think we had enough of a sample to really look at the type of caregiver relationship to really, draw conclusions about that. But I do think that we are on track to be talking about what the family caregiver experience is like by the health condition. So that it's a very different experience being, for example, a cancer family caregiver, where your day is going to look like trying to get someone to eat when they have mouth sores, or taking them for their chemo or radiation appointments. Looks different than if you're taking care of someone with diabetes who may need help with their insulin, or if they have very advanced stage disease with mobility issues, secondary to neuropathy or something like that. So I think that the confidence piece is probably, something that stretches across different caregiver types. The knowledge piece is obviously going to be different depending on what their day is going to look like. But I think that we need to dig down across each of these health conditions to gain more sensitivity on what the caregiver experience is like by health condition.
Thank you. We have another question. What are cognitive interviews, and are these generally semi-structured or unstructured?
So cognitive interview, it's also a very good question. Cognitive interviews are mainly done in instrument development. And they're really more about using kind of a think aloud technique to usually get feedback on instrument items. So again, it's not that cognitive interviews are only used in instrument development, but they are mainly used in instrument development. So these are kind of very straightforward questions. Overall, did you understand what this instrument looks like? Were there any words that you didn't understand? What was the ordering of the questions like? Did it make sense to you? Did you were any of these questions off-putting to you? Like say you're giving an instrument via computer, like was it easy for you to navigate through these pages? So they're not really questions about feelings. They're really questions about understanding so that you can refine your instrument. So it's a bit of a different thing, and your analysis process is going to be different because again, these are sort of straightforward responses that you could usually use content analysis for versus another kind of analysis that is more necessary when you have richer, more nuanced data.
Thank you. I feel the biggest challenge is the gatekeeper's role related to access to potential participants, especially bereaved individuals.
Mm-hmm.
How do we navigate our ways through that, especially if you're an outsider to that setting?
So the thing is that you can't be the outsider. You've got to do what you have to do to become an insider. And that may mean that you choose one enrollment site over another because you have that entree. But if you don't have that entree, because that may be the case, I think it's really helpful to sit down during the time that you're formulating your study protocol to share what your ideas are and how you think that this place might be a good partner for you in it, and what you would be looking for participants from that setting to be doing, and to see that you have that buy-in so that they can partner with you from the start. And to make sure that they know, because really what they want to know is, are you going to take care of our folks? Whether it's healthcare providers or patients or family caregivers or whoever it is, they're responsible for the people in their organization or interacting with their organization. And they need to know that they can trust you. And so, if they are your partner in developing the protocols and you share your interview questions with them, and that maybe if they're a study team member, that you can share a transcript with them so that they can see this is what we're doing and here's what we're learning from this, and that you keep in touch with them to say, here's how we're progressing, here's how we're learning. I like to go in and do periodic staff meetings and present findings to date. And again, with food, I think it always helps to solidify that partnership and to show your thanks, and for them ultimately to feel comfortable in that gatekeeper role, that they feel vested in connecting you with the people you need to get to learn what you need that's going to be of benefit to everyone.
That's great advice. Do you have any ideas on enrolling during COVID when most of recruitment has to happen virtually? We've noted that enrollment has been especially challenging.
Yeah. So I do think that there are challenges to rapport building via Zoom or whatever video platform one is using. And a lot of people say, well, I don't have the usual cues. But the truth is, this is a video interview. I mean, back in the day, we did phone interviews, and people didn't jump up and down so much about, well, it's a phone interview and I'm not going to be able to, get good quality data. It's maybe not as good quality data, but Zoom interviews are, leaps and bounds, more beneficial or like easier than phone interviews because you have the benefit of seeing nonverbal cues. So again, I think Dr. Fratkin's suggestions are really helpful in terms of making the setting as ideal as it can possibly be. But I think what your question is talking about is, how do I even invite someone to a Zoom interview? I think it's going to depend on how comfortable you think people are with using Zoom. I think at this point, a year into the pandemic, this is just kind of a way of life. I think the trickier thing is going to be for people who aren't so used to the Zoom interview. And that's something I would really think about. And again, making it as easy as possible for them. If there is someone in their home who is used to using Zoom, who can set them up and just have them ready to go, will take down whatever anxiety there is. And again, that acknowledgement is of, I'd really like to be in person with you. But I'm glad that I'm going to be able to hear about your experiences, even if it is in this different medium. But for some people, a Zoom interview just may not be their cup of tea. And if it's not, that needs to be okay.
Thank you. And on a related note, what are your recommendations for having these straight phone interviews without video?
So I don't know that people are using phone only interviews as much. because we have access to Zoom, but I do realize that sometimes the phone interview is the way to go. I think that the hardest piece is that because they can't see you, you're going to have to use your voice a lot more to establish rapport. So that's going to be in your tone, in your inflection, in your pauses, in because you're not going to be able to see them. Let me just check in with you. Are you doing okay? Do you need to take a break? Um, and I guess the thing is that um, because that connection isn't naturally going to happen, you're going to have to figure out other ways. So I don't know if even sending a picture of yourself to them, or even if there's some way that you're able to even somehow see them in person, if they're someplace that you can show up and give a wave. I mean, we know that even like a short first in-person encounter can be useful, even if the subsequent encounters are by video. But I just think that it's the phone interviews are tougher, and it opens the door more for over disclosure. You know, it's sort of like when you're in the car, people always talk about, you know, people spill when they're in the car. Like if you have a teenager or something and you're sitting together in the front seat, is that's when they really talk to you because you're not looking at each other, right? You're both looking ahead out the windshield. So that's what can happen on phone interviews. But again, this isn't a family member. This is someone that you don't know. So that's what I would just be kind of mindful of during a phone interview, that you feel like they're okay with what they're sharing with you. It would probably be my biggest concern.
Thank you. Another question. I would like to talk about when crying occurs during an interview. I
Hmm.
sometimes struggle trying to let them just be in their emotion, but also sometimes they need validation. Can
Hmm.
you speak to your experiences when a participant may have a very strong emotional reaction to the interview?
Hmm. So it's really hard. It's one of the hardest things is to sit in silence with someone. But if the nature of your topic is such that you think it's a possibility that someone will have a strong reaction, again, you need to prepare and develop your skills of being able to sit in silence. And in sitting with someone being emotional in front of you, because it's hard, you know, you naturally sort of you feel sad yourself, you feel sad for them. So I think when someone starts crying, first thing is you don't want them to feel like embarrassed. And so usually I just say, you know, it's okay. If I'm with them, I offer a tissue. If you're on Zoom, you can say, do you need to get a Kleenex? And to just say, you know, you can take a few minutes, it's okay, and just be quiet and let them sit with it. If it's a video interview, I wouldn't, you know, you could say if you need to take a moment and turn your video off, you can. I think that's something that in the moment you're just going to have to see what kind of support a participant needs. Um, but it can come up, and again, it's just preparing for what am I going to do. And if you are training someone who doesn't have a lot of experience, they need to be very well trained if this is a possibility, and you may need to even write out a protocol of what to do. And again, I think the thing is, are they going to rally and be able to continue the interview, or are you going to need to take a break or stop the interview? Because the main thing again is you have to take care of them. You're in the fishbowl. You got to take care of them so that when they're out of the fishbowl, they're going to be okay. And so that verbal check-in with them of what do they need is going to be pretty important.
Thank you. We have so many great questions left, but just one more minute left. Dr. Schulman-Green, would you be able to please pull up the PCRC slide so we can go over next month's PCRC announcement?
Absolutely.
Thank you. And if it's okay with you, I'd like to send you the remaining questions and maybe we can send those around, your responses to those.
Absolutely.
Thank you. So thank you everyone who's joined. Thank you, Dr. Schulman Green. If all of our attendees do go to our website, we have one more webinar coming up in the near future. Next month is a very exciting month. We have Doctors Catherine Doyon and Tamron Gray launching their Health Equity and Anti-Racism Special Interest Group with their webinar, Principles for Health Equity Research in Palliative Care. We hope you join us for that. We are also collecting applications for our next Dementia Palliative Care Clinical Trials Intensive. Those are due March 17th. Please check out the website for more information on that. We'll also be sending out an evaluation where we gather other topics that you might be interested in learning more about. So please take a minute to fill that out. Thank you again to our panel and for all of our attendees for attending. Take care, everybody.
Thank you, Dr. Schulman-Green. That was fantastic. And everybody come to the investigator meeting at the end of March.
Thank you so much.
Thanks. Bye.